Welcome everyone to our information and support session. Pain is both invisible and subjective. It can be difficult to understand and difficult to treat. My name is Kathleen Helgeson, and I'm the coordinator of the Patient and Family Resource Center. I'm joined today by Dr. Paul Danick, medical oncologist at Cancer Care Manitoba, who will be helping us understand cancer-related pain and answering your questions about treatment choices. We are very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojibwe, and Dene people, as well as the homeland of the Métis Nation. It's important for us to foster inclusivity and reconciliation and encourage others to do the same. Before we continue, there are some basic Zoom features I'd like to explain. You'll notice as an attendee, your microphone and your video are turned off. If you have a question for Dr. Danick at any time during the session, just click on the Q&A icon on your screen and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. My coworker, Ellie, is also here off screen, and she will be helping manage your questions as they come in. If you have a technical concern, you can also type that into the Q&A, and Ellie will answer your question privately and try to assist you. Our guest, Dr. Paul Danick, is a medical oncologist and palliative medicine consultant with Cancer Care Manitoba and the Winnipeg Regional Palliative Care Program. He's also an assistant professor in the College of Medicine at the University of Manitoba. Dr. Danick has served with several national organizations and is active in the education of medical professionals. His ongoing research interests include palliative medicine, including the use of medical cannabis in patients with cancer. Welcome, Dr. Danick. Oh, thank you for joining us.
Thank you for having me.
There, just your audio there for a second. We lost you. Yeah, thank you so much for making time for us today. I guess let's just jump right into the basics of cancer pain. What causes cancer pain?
Cancer pain is caused, there's a number of different causes, but I think that probably the most important cause is the cancer itself. Whether the cancer is putting pressure on a structure and you're getting pain. So for instance, what we would call a spinal cord impingement or compression, the disease is actually, the cancer is pushing on the cord itself, causing a lot of pain for that patient. It could be that the disease is affecting one of the organs. So if it's affecting the lung, for instance, you could be putting pressure on the inside of the chest. You could be putting pressure on a nerve. You could have a bone that's broken because of the cancer. And all of these are causes of cancer pain. We know, though, that cancer pain comes in a number of different flavors, and I think we'll talk a little bit more about that as we go along. But I think that we need to keep in mind that the cancer itself can be one part of the cause, and then another cause could be the treatment. So sometimes what we're doing is we're trying to help with cancer. We might use radiation, and in doing that, we might cause some, let's say, changes in the skin that could cause some pain for patients. Chemotherapy could cause a reduction in the white cells. People may have some swallowing difficulties or some mouth issues. Sometimes people get a numbness or tingling of the fingers and toes. That's not an uncommon thing with some of our chemotherapies. And then lastly, certainly there's some surgical type causes of cancer-related pain. So if a person has a resection of, let's say, the breast, or if they have a resection of their lung, they could be left with some neuropathic or kind of skin type pain that needs addressing.
Mm-hmm. And in general, does pain increase throughout the progression of cancer?
Yes and no. Yes, with some patients, depending upon where the cancer is, you can get an increase in pain that may indicate that you've got some growth of the cancer. It may also just mean that the disease has caused more structural damage, and that needs to be attended to. It could be the chemotherapy, you know, the disease might be getting better, but unfortunately the nerve damage might be getting worse, something that is very important and needs to be addressed or discussed with the oncologist. There are some patients though, you know, I saw one today in clinic where they have a pancreatic cancer and yet they have no pain. The pain is essentially zero. And we would scratch our head because we know that pancreatic cancer can be associated with pain. But there's anywhere from 10 to 20% of all cancer patients who don't experience pain, and that, therefore, it's not an unpleasant experience. There's a lot of unpleasantness associated with having cancer, but at least that's one thing that they don't have to worry about.
Yeah. And I mean, you're right in that the impact of a cancer diagnosis is life-changing for most people. And then to add pain into that, it certainly can impact one's enjoyment of life and being able to manage, the changes that are occurring. I think this might be a good time just to poll our audience and just ask them in terms of what their experience has been like with pain. So, pain of any kind can really have an impact. So let's just launch our first poll. So I'm going to send a poll to your screen and ask you to kind of reflect on if you had no pain, what would you do differently? How would your life look different? And if you're not seeing the poll come up on your screen, it may be that your current application of Zoom doesn't support it. So you can also just type a comment into the Q&A and Ellie will relay your answer to me as well. So we're getting some results coming in right now. Dr. Dana, can you see that coming in on your screen?
I don't see the results at the moment.
But you see the poll.
Oh, yes, I saw the poll.
Yeah, okay, great. Okay, sorry. Yeah, I guess the results don't show until I share them. I get to see them, but so we have about 60, it's going up to about 70% of people just weighing in on this. So I'll just give it another few seconds and then we'll share them. So whenever you want to close the poll to exit, you can do that. So we have 75% that have just responded. So I'm going to end the poll and then share the results with everybody. So are you seeing that now? Did you want to comment on those responses?
Well, I think that I think these responses are kind of reflective of what we see with some cancer patients. Pain often affects sleep, and 72% of patients said that they would like to sleep better if they didn't have pain. And pain it's stimulating. It's more stimulating than sedating, let's say. So people who have bad pain, uncontrolled pain, often are complaining about poor sleep or disturbed sleep. They aren't able to get a full night's sleep. So we often are looking at how can we treat pain to make this better? What if we treat both at the same time? We might be able to get some help. Exercise, same sort of thing. It could be that moving the arms, the legs, moving the body causes more pain. Therefore, people feel that they can't do as much. They might be sitting more often. They might be lounging. Sometimes if the pain is that bad, you might be spending more time in bed. So, they often feel like, some people have described themselves as couch potatoes or bed potatoes. So I could see that.
Yeah. And it's kind of unfortunate because we know that is so important, even in terms of just how people respond to treatment and reducing chances of reoccurrence. And yet, if there's pain, then you're not likely to want to be exercising, as you said. Just when we talk about quality of life, and I'm just going to close that poll right now.
Okay.
How do you distinguish between the pain that is related to the cancer and pain that's related to something else?
That's a great question. Many patients who come to cancer care already have a pain of some sort. They may have a complex pain. They may be having more chronic pain. They may have received treatment for that. Definitely, we want to ask patients, when we see patients in our pain and symptom clinic, we ask them, what was your past experience with pain? Where have things worked? What hasn't worked? It's important to know because we don't want to go down a path that didn't work for them. We also want to find out, what was the cause, if possible, what was the cause of some of the pain that started out? So a patient who has rheumatoid arthritis, it's a different type of pain and definitely a different type of treatment than a person that comes to us with low back pain, for instance, or post-trauma pain. That could be problematic. We We luckily have Dr. Lindsay Woodrow on a staff. She's a rehabilitation specialist. It's also known as physiatry. And these people are really helpful in terms of getting people back to function. So they not only, the Dr. Woodrow would focus in not only pain, but what sort of things can she do to increase the function of that patient. So as you said, those who can't exercise, how can we make it so you can exercise? And in doing that, we can help with the pain. So it's nice to have that because Dr. Woodrow can also do things like injections. She's been trained to do injections in certain muscles, certain joints, that sort of thing. And she has all that background of rehabilitation. So how do we get people up and working? How do we use different types of equipment? Can we bring in things like even something as simple as having a compression garment for the hand or the foot might make a difference for that patient in terms of pain and function.
So when we're distinguishing between cancer-related pain and pain from a maybe pre-existing condition, are there certain diagnostic tests that can really help identify where the pain is? I mean, because I think almost everybody I know my age is experiencing pain of some kind, and everybody's always speculating what it is. Like nobody seems to know like what's causing this pain. So I imagine that this can cause a lot of anxiety for someone that has had a diagnosis of cancer. And so are there certain tests that are really effective?
Yes, and again, no. So, it's a really good question. How do you isolate or how do you tell where this is coming from? I think it's really important to get that history and to kind of hone in on where that pain might be. So a person who has low back pain, they might talk about, well, that's minor now compared to the pain that I've got in my shoulder or the fact that my feet are burning every time I get out of bed. So sometimes we'll be looking at, okay, can we do some investigations such as a CT scan, a chest x-ray, MR to have a better examination of the area. Sometimes we might definitely we want to do a physical exam and have a look at that one area as well. If those aren't helpful, then we can do things like even a bone scan or a simple bone x-ray sometimes can be very revealing to us. CT scans might be a little bit of overkill, if you will. Blood tests can be very helpful for us as well. What's going on? People can develop pain because of high calcium. They might have, kind of total body pain because of that feeling of high calcium. And that treatment is to use a medication to bring down the calcium and to keep it in the bones, which is really important.
Could you just clarify like what causes the high calcium?
It's often a state where the cancer has tricked the body into thinking that the calcium is low. So a classic example is with myeloma. The myeloma cells affect the body, they affect the bones. They're telling the bones, oh, you don't need all this calcium, just put it into the bloodstream. And that calcium can get so high that people become somewhat confused. They can have pain, they can be very nauseated, very fatigued. We will check that calcium, we see that it's very high, then we use medications to put that calcium back into the bones. So it's the cancer's way of tricking the body and using that to its own advantage. That's how cancers tend to live, grow, migrate, things like that.
Right. So in the resource center here, we have this brochure, or like a little handout card on the fifth vital sign. And I was wondering if you could talk a bit about that and explain what that is and what the other 4 vital signs are.
So when we talk about vital signs, we're looking at simple but very telling things. So what is your body temperature? Do you have a fever, or are you hypothermic? In other words, is your temperature below normal? We look at blood pressure. Blood pressure can be very helpful in terms of, what's your blood flow to the body. If it's a high or a chronically high blood pressure, that can tell us a little bit more about your heart and things. The respiratory rate, is it normal? Is it high? Is it low? And the heart rate, these are vital structures, vital organs that we need to know about. It was proposed some time ago that because so many people present with pain, that addressing the pain or understanding more about the pain would be another vital sign. We know that when we're looking at what we call demographic data, probably about a third of people, just people, not just patients, but a third of people have some form of pain that they're dealing with. Often it's minor, not of a big nature or an overwhelming nature, but so many people have sort of chronic pains. And as we get older, and Kathleen, like you, I'm getting into that age where I sometimes wonder, what's that pain about? And so because of that, there's a lot of attention to be paid to that. I think it's also important because pain is the body's way of saying, hey, here's a warning, something's going on, something's not right. So we should be watching out for that. And, you know, it's one thing to have pain in the muscles after you were a weekend warrior and you did too much work or too much exercise. But it's another one completely when the pain is localized to a point where you're saying, well, that's unusual. Why would I have pain in my rectal area? You know, that could be a sign of a cancer. Or, you know, why have I got an open wound that's painful in the back of my mouth? Again, you know, these sorts of things are trying to stimulate or alert us to something that's not quite right and needs to be addressed.
Imagine it must be really difficult for somebody that's finished treatment and maybe in remission with their cancer, and then having that anxiety about new pain that's occurring in the body, even if it's not related to cancer. Do you have a lot of questions about that in working in this field?
We do. What we find is that patients who have undergone chemotherapy or have undergone treatment and they're now thought to be disease-free, they have a heightened awareness of, you know, is this situation cancer? You know, I'm not sleeping well. Is that because the cancer is back? I'm having more troubles with my bowels. Does that mean that the cancer is back? Or, you know, we're having trouble with pain. What does that mean? Is that a sign of the cancer coming back? And often we're having to sit down and really talk to patients about that. And again, I think it's really important. That could be an early sign. So we want to be sure to rule out that this is cancer. And we also can reassure them that, oh, look at this. We've discovered that this is more arthritis than it is anything else. And we can't see any cancer. You know, you can feel pretty comfortable with that. That's one of the reasons that we have routine follow-up in the first few years after we've treated a cancer. We know that cancer, if it's going to come back, it's probably within the first 2 to 5 years. 2 years especially are important. And that's why we focus in on those and we see patients so often. Some patients say, how come you're seeing me every 3 months? Well, it's because the risk of cancer is high. If you make it outside of that, that risk starts to drop off.
So when you're discussing pain, and I've often had, you know, I guess not often, but I've had that experience where people actually ask you to rate your pain on a scale of 1 to 10. What is the difference between asking someone that and asking them to describe their pain, and are both helpful? How do you assess that?
Well, 1 is an intensity. So the strength of pain, 0 to 10, 0 being no pain, 10 being the worst pain that you've experienced. Tells us about the impact on the patient's quality of life. So a pain of 2 would be minor compared to a pain rated of 8, 9, and 10. That means that the pain is really interfering with their quality of life, with their ability to do things. Describing the pain helps me to determine what kind of pain it is. So a person that says that it's sharp, it's, you know, in one particular area, it worsens with movement. I go, maybe this is a bone pain. Maybe this is associated with the muscles in that area. Let's focus in on that. A person that tells me it's burning, it's tingling, it's like an electric shock, it's like someone is twisting a poker or a knife in that area, I start to be concerned, could this be a neuropathic pain, a nerve pain that's either an involved structure, or possibly, you know, could this be secondary to treatment or surgery? And then those are very different pains, and they're treated differently as well. You know, throwing one drug at 2 different pains and seeing which sticks, that's one way to do it. Or you could say, this pain is this, and this is the focused drug that I want for that. This pain is a different pain. I have different, better drugs for this, rather than just throwing things at you.
Right. It must be really tricky though, because it is such a subjective experience, that how, I mean, some people don't articulate their kind of what's going on inside their body as well as other people
Yeah.
do. And, I imagine that that must be part of the challenge.
It can be. I mean, we also know that people who don't have, like, can't describe their pain very well, that might be a sign of some mental health issues. Not negative ones, but just that their brain is so overwhelmed with other things, pain doesn't necessarily take a prominent role. People who are depressed feel more pain. There's how would I say it? They feel that the pain is worse. They may give you a higher pain number than you would have expected with that. But you do have to take them at their word and say, okay, this is a pain that you're feeling. How are we going to treat it? And it might mean that we treat not only the pain, but there might be a depression or an anxiety around it that we want to look at.
As well, right? So when you begin to treat that, I've heard the term the analgesic ladder. Could you talk a little bit about what that is and how it's used?
So back in the 1970s and the 1980s, the World Health Organization felt that pain wasn't being very well addressed, very well treated, and they wanted to make something or develop a model that was easy enough for people to see, for physicians to work with, and so they developed this ladder. There were 3 steps on the ladder. The step 1 was mild pain, so that you were using a drug like acetaminophen or even something like ibuprofen. Step 2 was moderate sort of pain, and they were using the drug codeine as a model to use that. And then step 3 was severe pain, and they were using morphine as the model for that. Things have changed over time. We've got more technology, we've got better medications or a wider range of medications. So more recently, there's been a proposed 4th step where it's called interventional or procedures that should be given for, quite severe pain. And that's where our colleagues like Dr. Woodrow or our anesthesia colleagues who can do things like nerve blocks can be very helpful.
Great. Yeah, and we're going to talk a little bit more about that too in terms of some of those newer types of treatment. Just going back to kind of the baseline, I guess, in terms of using acetaminophen and ibuprofen, what are the daily maximums of that? That just with the kind of drug that you buy off the shelf, like are there certain amounts that you should only take, and what are the side effects of taking too much?
Sure. Acetaminophen and ibuprofen are the 2 basics that many people use. They use it over the counter for things like headache, or they might use it for other sort of mild sort of pains. Acetaminophen on its own is not a bad drug. It doesn't cause big problems. But if you're taking a high dose over a prolonged period of time, let's say people with more chronic pains or chronic headaches, then you can cause some liver damage. And now, when I say over a long duration, I mean years. I don't mean just a couple of weeks. I mean someone who's taking it over the years. And generally, we say that anyone who's 65 and older should not take any more than 3 grams of acetaminophen per day. That would be the equivalent of 6 extra strength Tylenols or acetaminophen tablets. People who are under that, somewhere between, let's say, 30 to 65, we usually talk about 4 grams. You can get up to about 4.5. But you do want to be able to limit it. It's not one of these drugs that is limitless, that you can take it until you get benefit, sort of thing.
And what about for the you pronounce it differently than ibuprofen?
Oh yes,
Yeah.
ibuprofen. So that's Advil or other drugs like this. Aleve is another drug that's in the same
Mhm.
family. We call them non-steroidal anti-inflammatories. Very useful, very helpful for many patients, and especially if they've got some inflammatory contribution to the cancer. The cancer may be causing a lot of edema or swelling in there. If we can reduce that inflammation, that can be helpful. The officially, there's no limit to the amount of ibuprofen we could take. However, we find that there are people who have stomach upset with ibuprofen. So we generally talk about possibly no more than 1,200 milligrams per day. Ibuprofen comes as a 200 milligram or a 400 milligram tablet. 400 milligram is probably what we see most people taking. So if that's the case, then 3 of the 400 milligram doses per day would be kind of a a maximum for some patients. The absolute maximum we talk about is about 3,600 milligrams a day. So that would be the equivalent of 2 of the 4 milligram tablets up to 6 times a day. And that could be, excuse me, that can be quite a bit for some people. They may get a lot of stomach upset. Sometimes it might be very effective. So we might need to say, let me try to protect your stomach as we treat this. But then you're often using one drug on top of another on top of another, and that can be problematic for some patients.
Is there a certain point where you would say if people are taking that much of those medications, acetaminophen or ibuprofen, if they're taking that much, at a certain point, would you say that's not working for you? Like,
Yeah, absolutely. And we assess that in a couple of ways. First off, are they taking the drug? Does it work? And if they say, hey, it doesn't, it never takes away the pain, it just kind of takes the edge off, well, that tells me that it doesn't have the potency. So we need to have something a little stronger. Or they take it and only lasts for a couple of hours and then they're back into pain. These drugs are usually last anywhere from 4 to 6 hours in the body. So it's telling us that they're just not getting the benefit. And at that point, we start talking about other medications. Sometimes we can say, can we get you a combination drug? So a little bit of acetaminophen with another painkiller like codeine or oxycodone. Or should we go up to morphine and the whole family of morphines, as we know that they're a little bit more powerful than that.
right. And just with those two drugs, acetaminophen and ibuprofen, you can take them together as well. You can mix those.
That's correct. Yeah. And in fact, some people find the acetaminophen works and then they kind of alternate with the ibuprofen. They feel that that's working to help their pain. They don't feel that they need to go on to something else, but they are taking something every 4 hours then.
Okay. So now you mentioned about moving up from there, the morphine. Is that an opioid? Is that considered an opioid?
Yes, morphine is from the family of opioids.
Okay.
And opioids are specific medications that are derived, originally they were derived from the poppy plant, but now we have a number of what we call synthetic opioids, and they tend to follow the same structure, but they also it will target the opioid receptors that we have in our own bodies.
And so would fentanyl be one of those? Fentanyl
is what we call a synthetic opioid. A very, very effective opioid.
Right. So there's a question from one of our audience members says, I take fentanyl for pain, but it affects my breathing sometimes more than other times. Is it possible to get some type of oxygen for this? Is that something that you've noticed in other patients, that there's breathing issues?
Right. So opioids have some side effects. One of them can be a reduction in the ability to breathe. That usually is, though, something that we know we develop tolerance to. So it may start, you may have to watch patients for a period of time when they're starting out with the pain medication. If that continues, though, then absolutely the use of oxygen would be helpful. Or what you might want to do is adjust the dose of fentanyl. Fentanyl might be really good, but maybe the dose is a little high. You could actually bring it down. Fentanyl comes in both a patch as well as kind of a sublingual intravenous liquid that you can use in that way. And so you can use a smaller dose and still get the benefit without causing this sort of reduction in your ability to breathe.
Right. So are there any other side effects with opioids that are important to know about?
Yeah, so our bodies have opioid receptors in a number of different places. A lot of them are in the brain, of course. That's where a lot of our pain gets, how would I say it, analyzed, and then we act upon it there. But we also know that we have some opioid receptors in our lungs. We have some in the abdomen. And so when we take an opioid, whether it be by mouth or by other ways, we can activate some of those. And especially in the bowel, for instance, it slows the bowel. So suddenly you can develop some constipation or some very, hard to poop sort of thing. It can cause, because it's in the brain, it can cause some drowsiness or some sedation, especially when we excuse me, when we start off with that medication. It could also cause that breathing that we talked about there. It can cause some dry mouth because there are some opioid receptors within our mouth, and there's some crosstalk between that and some other receptors. So there are definitely some side effects. Some of those would be treated, like constipation. We would use a laxative, I guess, sorry. But if the person is feeling so much trouble that their bowel is so slow, they're feeling nauseated, you would also use an anti-nauseant. So sometimes you're looking for, yeah, this opioid isn't necessarily the best for you. Let's look at a different one. And different ways that they're delivered, different drugs can have different effects on the body.
So is there a tolerance that builds up for people when they're taking opioids, that they need more after a certain time and they start to feel pain, they become sensitive to pain? And then the whole risk of addiction, is that a reality that you see?
So there, you bring up two important points, and I'm just going to separate them out because I think they're important to talk about. Tolerance is where your body says, okay, that amount of drug helped that pain, but now I need a little higher amount because my body's just getting more used to it. It's saying that, yeah, that drug, I need a little bit more of that. So that's a more of a tolerance issue. And often just an increase in the medication will work really well. You'll be able to recapture that pain control, and then that won't be a problem. Dependence is another term that we use where the body usually makes its own sort of painkillers, but when we give people a pill that's a painkiller, what we call exogenous or external to our body, the body becomes lazy. It says, I don't need to work as hard. Why should I make all this painkiller when you're not using it? You're using this one. So your body becomes physically dependent upon the drug. If you were to stop that medication after a certain period of time, just cold turkey, that's it, your body may rebel and say, hey, I need some time to remake these natural painkillers. And people may have what we call a withdrawal reaction. They may feel cold, they may feel somewhat nauseated, they may have diarrhea. So it's kind of the opposite of what happens when you start one of those painkillers. Yeah. Addiction is another thing altogether. It's where your brain gets enjoyment, if you will, out of taking the medication. And it's not just the enjoyment of no pain, but it's beyond that. So, people who have difficulties with the use of alcohol, people who gamble, people who may have other addictions or what we call substance use disorders, they use it and then they benefit, they high or whatever it is, the euphoria that they're getting, and then they develop what we call craving. The brain says, that was good, let's do it again. And so it's that constant cycle of, I need to get some more drug to get that same feeling. And it's often related to either genetics. We know that there's a genetic, underlying sort of genetic issue with people who have addictions. They may have had that in the family. But there's also the whole thing around, are they using this for other reasons? Have they had trauma? Have they had abuse as a child or as a young person? Are they trying to escape some issues that are ongoing? When there are homeless people who are using drugs, that's often the underlying issue, that they've got a lot of other things that are going on. People with cancer rarely develop addictions to these drugs unless there's an underlying or a previous trouble with addictions. And in fact, I have a whole number of patients who have been on these pain medications for years, and they still don't have any troubles with addictions or, needing more and more. We just hit the sweet spot, so to speak, and we're able to keep them comfortable, but functional. And I think that function is what's important. If you spend your life chasing the next hit, or you're chasing your life for that next dose of drug, that's not a function, that's a dysfunction.
Okay, thank you. Somebody asked a question about what they can do if they're allergic to pain medication, for example, codeine.
So codeine is a natural product. It is derived from the poppy directly. Morphine is also a natural product. It's derived from the poppy. However, drugs like fentanyl, sufentanil, methadone are what we call synthetic medications. Tramadol is another drug that's synthetic. They do not share the same structure or all the same structures. So these are drugs that are much safer to use in those people who have had true allergies. People who get short of breath, or people who have rashes when they're taking morphine or codeine. People who have some nausea or constipation, that's a reaction, but that's not an allergic reaction. That's a known side effect to it.
Okay. Letrozole, is that part of that family? Somebody's asked a question that letrozole is causing aches and pains and to soft tissues.
Yeah, so letrozole is actually an estrogen blocker, and it is used for patients who have breast cancers or ovarian cancers, because estrogen can make the cancer grow. So if we block it, we stop the growth of the cancer. It is not related to morphine or any other opioids, but what it does do is, because it removes the estrogen out of the body, we do get those sort of aches and pains. It's the same as if we're blocking the testosterone in a male, we tend to get aches and pains because the bones, the muscles depend on some level of hormones for their health.
Okay, so is there a medication then that's prescribed when somebody's on letrozole as well to help them with that?
Yeah, it's a bit tricky because we can't give estrogen or estrogen-like drugs. We really don't want to, turn on the cancer or feed the fire. So what we do is we look for, are there other medications that can help? So something like ibuprofen can be really helpful for many patients. This tends to be more inflammatory in nature. The body or the bones and joints are the ones where they notice this inflammation. Some people do need stronger sort of medication. So we might be looking at something like tramadol, which is, again, that synthetic sort of opioid. Rarely do we have to go to something like morphine. Sometimes what we need to do is just switch the drug. If letrozole, if they're not getting benefit from that, then there are about 4 or 5 different drugs in that family. And some of the other ones don't cause the same sort of pain and discomfort.
Okay. Somebody also made a comment about that, feeling that there's too many medication begins to affect their sleep. Is that a side effect that you see?
It can. And again, it's this whole problem of, well, here's a drug, but it has a side effect. Let's treat that with another drug. Oh, they have a side effect. Let's treat that with another drug. And suddenly you get, a number of medications, and you may have direct drug interactions. Sometimes it's a cause of the medication itself. So a drug like dexamethasone or prednisone, great drug, great anti-inflammatory. We use it in chemotherapy. It's a great anti-nauseant, but it also is a stimulatory drug. So it stimulates you, and it can cause a lot of insomnia for patients. So we often say, let's try to use the minimum dose, try to put it in, start it off in the morning, try to minimize that, or look for a different option.
Right. In terms of, kind of keeping track of all this, I've heard the idea, and we have some brochures here in the library about keeping a pain diary. Could you talk a little bit about what that is and how it might be helpful?
So pain diaries come in a number of different formats, but essentially it's a piece of paper that has a grid on it. You would put down the medication, what you're taking and when, and you'd also be monitoring the pain. So if it's the burning pain, you might say burning pain. It came up at 8 o'clock in the morning. I took my pain medication at 8:05. Burning pain was better by 10:30. If you've got a second or third type of pain, you might put that there, and we'd be able to kind of monitor it. You'd look at that, kind of map it out and say, well, look at this, we do pretty well in the morning, but mid-afternoon, the pain comes back, and you're waiting until the supper time to take your second dose of the medication. We might need to modify something. Maybe we need to throw in a third dose of this longer acting medication. So visually, it helps us as the physicians immensely when you bring that in, and then we can kind of look at it and say, aha, there's the problem. Let's work on that.
Right. So there's been a couple questions already about how do people get referred to the pain clinic? How do people get a referral to Dr. Woodrow? Is that a difficult process?
It's actually not at all difficult from
No.
within cancer care.
Okay.
All of the physicians are aware of the pain and symptom clinic. The referral would go to Dr. X pain and symptom clinic. So Dr. Gingrich works with us. Dr. Woodrow works with me. And then there's Tamara Einerson, who is a nurse practitioner who works with us as a specialist in pain and symptom management. So there's the four of us that see patients. We have a number of different clinics through the week. And it's very simple. You just ask your oncologist to refer, and they're often, they don't see any problem with that.
Great. Okay, good to know. You mentioned about Dr. Woodrow administering shots. Is that for nerve blocks? And could you talk a little bit about what that is?
Yes, she can use some medication to block the nerve. So I'm just thinking of how to phrase this. If a nerve actually stimulates or kind of takes in information from a certain area, a certain location on the body, and if we know that where that nerve starts and goes to, we know it ends up in the brain, we can actually put some medication somewhere along the path and block the transmission of these messages. We want to be able to stop that message from getting up to the brain, being interpreted as pain. So sometimes we can use anesthetics like lidocaine or bupivacaine. There's a whole family of drugs like that. And you can inject it right into the area, and it just deadens the nerve. The nerve isn't dead; it just doesn't send those messages along anymore.
How long does that last? Sorry, how long does that last after you had the injection?
Yeah, very good question. So some of the medications may last just for a short period of time, a few minutes to a few hours. The longer it lasts, the more effective it is. And Dr. Woodrow might say, aha, this one works. Let me get a longer acting version or a version that will last for several weeks, several months as we do that sort of injection.
Okay. Can we talk a little bit about peripheral neuropathy and,
Sure.
and what that is and how it's caused?
Well, by the name, peripheral means anywhere in the hands, the feet, outside of the center. So it is not causing troubles in the brain area. It could be a type of nerve change where you have burning, or you could have cold, like icy cold fingers, or icy cold feet. And that's not necessarily related to just living in Winnipeg during the winter. It's because the nerves are interpreting the messages and they're saying, hey, there's some pain here, but this is how I'm interpreting it. The peripheral neuropathies are an issue for approximately a third of all cancer patients, just because of the chemotherapies that we give. We're trying our best to determine who's going to do better with smaller doses of chemotherapy, or are there ways that we can prevent these from happening? Lots of research has been done. We haven't found the best medication yet. That's been a bit of an issue. But certainly those people who have these sort of peripheral neuropathies, this neuropathic type pain, there are a number of drugs out there that can be helpful. Drugs like pregabalin is one of the choices I use. There's another from a family called the antidepressants. Venlafaxine can be helpful. Nortriptyline can be helpful. So there are these sort of medications that have been used in clinical trials and have shown good benefit. It's often, we trial these and we need to give it anywhere from 3 to 4 weeks to really see the benefit, because these are drugs that work slowly. They're different than opioids. Opioids, first dose, you might get benefit within, that half hour to an hour. But opioids don't work very well in neuropathies. They don't work very well with nerve pain. And in fact, about only half of patients will get any benefit to an opioid with nerve pain. So that's often not our first choice. We actually list it as a second or third choice in the schema.
So neuropathy that's been caused by chemotherapy, does it go away after a certain amount of time, or can it last forever? One of our guests asked that question, or one of our audience members.
Right. So about 2/3 of patients who experience neuropathy with chemotherapy have resolution over a period of time. And it's thought, and I'll be honest, the research isn't super clear, but it's thought that this is because the brain, the body has to regrow that nerve over a long period of time. And when we think about it, the nerve that goes to our big toe is one of the longest nerves in the body. If we were to cut it and then let it to grow again, if it were to grow again, it would take about 3 years for it to grow from its entire length. So that kind of makes sense. Excuse me, about a third of patients still have some issue with pain. It may improve over time. It may, kind of settle and go away over time, or it may persist. And I do have some patients who have had bad troubles with pain for many years after their treatment. And it's a matter of finding a medication or medications that may work to help them get back into function, to get back to whatever they want to get back to.
Besides chemotherapy, do other treatments in cancer also cause pain and long-term pain for patients?
Yeah. Radiation, for instance, if it's given a large amount of radiation, it can be a curative dose, but sometimes it can cause changes within the muscles. The muscles can become very fibrotic. The nerve can be damaged and not be very receptive to those messages. So radiation in some areas can be a problem. Surgery, as simple as cutting open the chest to take out that lung cancer, we could cause some changes in the surface nerves, and you can be left with kind of a burning area. And some of those can be treated not necessarily with pills, but rather something topical if it's a very localized area that's a trouble.
Mm-hmm. And so does surgery cause neuropathy as well?
Yes, but not very much. It's very uncommon that it would cause it. You may get a little numb patch, but it's unusual for that to become really painful and ongoing problem.
Okay. Someone asked a question here. What kind of pain medication or therapy is available for deep pain in muscle and tissues as a result of fibrosis in the surgery area? So you mentioned that is that what you were saying there, like it's a topical pain or topical ointment?
Yeah. Those sort of muscle fibrosis, sometimes it takes some topical medication that can focus in on that. Sometimes you want to use components that will be able to drive that medication from the top into the muscle. Sometimes an injection right into the muscle, what we call an intramuscular injection of a pain medication, could be helpful. Sometimes you're looking at other things like transcutaneous nerve stimulation, where they use kind of a very mild electrical current to convince the body that the pain isn't there, and it starts to change the messaging to the brain. So those are sorts of things that we do look at. And the other thing that we know is, oh, sorry, I was just going to say, more use of the muscle helps to allow that fibrosis to reform and to, you can actually help the muscle. It honestly is a little painful to start with, but the more you move it, the more exercise you get, the better the results are in the end.
Okay. And this is a related question. Following a lumpectomy and 24 radiation treatments, is it normal to have a sore breast a year later?
Yeah, it will. Yeah, absolutely. We say, especially for radiation, this may improve over several weeks to several months. Mm-hmm. But we do know that some people do have some tender areas. They may have some painful areas for quite a bit longer. At that case, we also want to have a look and say, okay, is this a peripheral or a surface neuropathy? Is there something that we can use for that? Is it, does it respond to drugs like ibuprofen, or do we need to find something that's going to help reduce some of that painful stimulus right on top?
Right. And this too is similar. Somebody else has made a comment about having surgery and radiation in the neck area, experiencing a lot of pain. And is there something that they can do to lessen that pain? They're beginning to think it's going to just not go away.
Yeah, so that's where someone like Dr. Woodrow or going to a physiotherapist, a specialist in head and neck areas would be helpful. Again, you're trying to move those muscles, and no question, after radiation, those muscles become a little bit more shrunk. It's harder to get them to move, but once you start doing it, it does improve. Head and neck cancers, they're a challenge for me as a pain doctor, because I know that the reason that they've used these medications, this radiation, is to cure. We want to get rid of that cancer, and it can be very effective. But sometimes, because of the nature, the skin is a little bit thinner, the muscles are thinner, and they move, there's so much activity that goes on in our necks and heads. They're kind of very mobile but thin muscles. A little bit of radiation can cause quite a bit of damage. It's a little different than if you're radiating, let's say, the gluteus, the bum. Big muscles, often they don't have any problems at all. You can still walk, run, etc.
Yeah. And this too, I guess, is related to that area of the body. Does cancer, if you have cancer in another area of the body, can it affect the esophagus or throat?
Yeah, and that often is the case with chemotherapy. So good example, the person who has rectal cancer is undergoing chemotherapy for it. You can get either some esophagitis, which can cause burning pain. You can get what we call GERD, or esophageal reflux in that area, more acid. That could be, heartburn. So it definitely is going to cause some pain. Sometimes, though, chemotherapy can reduce the number of white cells, infection-fighting cells. And because of that, you may actually affect the inner linings of some of our organs. The esophagus is a good example of that. So people get this, terrible burning. They might get some heartburn associated with it. And we just have to wait for the cells of the esophagus to reline itself. We often, when we see that, we often say, well, let's adjust your chemotherapy a little bit to prevent that from happening again.
Okay. I have a few more questions, but I think I'm just going to leave them and bring them in a little bit later in our discussion. And maybe we could just talk a little bit about this concept of total pain and what that means.
Total pain is a term that was coined by Dame Cicely Saunders, who developed the modern model of hospice and palliative care. She noticed that a lot of people who had that were really suffering, having a lot of distress from their pain near the end of their lives. It wasn't just the physical pain, it was a number of other modalities that were involved in it. So things like emotional issues. They may have started to grieve their own death, or they're very worried about their family members. There may be social issues going on. There may be some financial toxicity, like I'm being treated for my cancer, but where's this money coming from? What am I leaving to my family? So taken it together, they would call that, Dr. Saunders called it total pain. And so throwing a medication to help the physical pain helps, but it doesn't address all of the issues. And that's often what we're needing to do. If the pain is something physical and we can treat it, increase the function, great. If we find that we're just not getting there, that there's so many other things going on, we need to address the whole person. We have to address all of the issues that are going on. And we see that every so often. A person who's going through treatment for a cancer has so many other issues. We need to treat each of those issues to get benefit even from our chemotherapy.
Mm-hmm. I'm going to just launch our second poll. I'd just like to check in with our audience again on this point here. So I'm going to launch this next poll and just asking what other factors in your life can worsen your experience of pain. So hopefully you're seeing that poll on your screen now. Somebody else in our audience had asked, is there such a thing as psychological pain? And I guess is this what you would consider kind of a psychological factor? This idea of total pain?
Yes, absolutely.
Yeah.
Psychological factors can contribute to it. So, as we talked about earlier, a person who has a great deal of anxiety, maybe it was, they had pain as a child or pain as a younger person, and their fear of pain is palpable. And so we need to treat that anxiety. We need to treat the physical pain. but we also need to look at what are the other factors going on. Can we treat that anxiety with other sorts of therapy, behavioral therapy, or talk therapy? Do we need to use another sort of anti-anxiety medication? Sometimes just the treatment of that will mean a benefit to their pain overall.
Okay, I'm just going to end the poll there and share well, there's just a few more responses coming in. I'll just give it in a few more seconds here. We're almost up to 70 again. And does that happen quite commonly, that there are referrals made for supports through psychosocial oncology where they can meet with counselors and process some of that other stuff that's going on?
Absolutely.
Yeah.
Absolutely. We work very closely with our psychosocial oncology counselors. We want to make sure that they're getting, they have the full resources, both as terms of support, emotional support, and just the ability to share the stress that they're under. And you look at that, stress is a huge problem for people.
Huge, yeah.
And, you know, you can think of stress as being going through just the whole diagnosis, the treatment of cancer, but there's also other things. We all have a life. What's happening in the rest of your life? You know, is the treatment of cancer causing financial stress? And that can cause, you know, kind of a heightened awareness of things, maybe minimizing some of the pain because you got to get back to work, or you're still having to work despite the chemotherapy, the treatment, the visits that you're undergoing. That could be really problematic. It could be that you're looking after children. You could be looking after grandchildren just because of the family dynamics. All of these things play into it.
Yeah, so just like the daily stressors themselves can really compound things. I did want to ask you, just because it's timely, the financial aspect of medication, and especially with advancing cancer, are there support? Is there support for people that find that the medication that they have to pay for it, it's just too expensive?
And, you know, that's something that's interesting because many people feel, well, Canada has socialized medicine. We don't pay for things. We have pharmacare. Yet there's still, you know, a deductible that needs to be paid when we're talking about pharmacare. It's based on your income, or there are some medications that are covered under what we call the cancer drug benefit. The government of Manitoba has very kindly said that they will cover both chemotherapies, whether they be oral or intravenous, as well as some of the supportive drugs, but they have not agreed to cover pain medications. And that's always been a bit of a bugbear with me, that, you know, so many of these patients need this pain medication. They're obviously undergoing chemotherapy. Why can't they cover this? Certainly that becomes a bit of a problem if you have a high deductible and you're not working, you don't have a lot of income coming in, or if you're on a restricted or a fixed income, that sort of thing can be problematic. We also know that some drugs are more expensive than others, and sometimes we have to search out, well, let's use this one, which is cheaper or comes as a generic, versus this one that's still still under patent protection and you're paying for a premium. So those are things that we have to look at. We do know, though, patients who are on the palliative care program, whether it be in rural or within the city, have their drugs paid for. The deductible is actually waived. So drugs like all the painkillers, some of the newer drugs, some of the more expensive drugs will be covered under palliative care. Unfortunately, we're still negotiating that whole thing of how, as a person who's taking chemotherapy, they need the support of the palliative care program, but yet it's an either or, black or white. And we need to explain to them that, yeah, there's a whole bunch of colors and a whole bunch of grays there. So we've been working on that for a number of years.
Yeah, I mean, that it would be a huge stressor, just the financial aspect of some of those costs. I'm just going to move on to our last topic. We wanted to talk a little bit about alternative and complementary options that are available for people, and maybe we'll just get into that discussion a little bit, and then I'll leave some of these other questions that we have for the end. But why don't we just talk a little bit about some of those things that are out there, and then we can maybe check in with our audience about what things they've already tried. Can you tell us a little bit about Botox and its use in treating radiation fibrosis?
So Botox, botulinum toxin, has been used in a variety of places. Some people use it to kind of smooth out wrinkles. It tends to cause some mild paralysis of the muscles in there. By doing that, you actually smooth out these things. So that's the cosmetic reason behind it. But sometimes it can actually, if you, let's say you have a muscle or you have an area of the body where you're having pain because of that tightness or that fibrosis, Botox may be able to reduce that, decrease the sort of spasms that you're getting, relax the muscle, and in doing that, you can reduce the pain. It has been used in a variety of painful conditions and has shown some benefit. Again, this is a place where Dr. Woodrow has a lot of experience with. These are generally interventionists or people that can use or are trained on how to do these injections. The Chronic Pain Clinic, the Pan Am Pain Clinic does a lot of that. Dr. Woodrow is still developing that, and hopefully she'll be able to give it to patients very soon. Again, pharmacare is quite restrictive as to who can get that. They do not pay for cosmetic use of Botox, but they will pay for some specialized pain reasons for Botox.
And how about needling? What is needling exactly? I've heard people talking about this, and it sounds like acupuncture, but it's not. So, but it sounds like it's a bigger needle. That's all I know. But could you talk a little bit even about the difference and just those two types of treatment?
Sure. Acupuncture, you're using very thin needles. They have been developed over about 3,000 years. This is a procedure that was developed in China many millennia ago, and it takes advantage of what they call, and I'm going to probably mispronounce this, qi, the life, sort of the life. In your body, there are certain lines of qi that they target. So they might say, well, if I put a needle in this place, the headache will get better. Or if I put the needle in this place, your bowels will improve. And because this has been used over so many thousands of years, there has been a lot of benefit to it. You definitely want a trained practitioner. You don't want someone that watched a few videos on the internet and says, "Oh, I know how to do that." Many of the best practitioners have been trained in China, and then they have come back here. Or traditional Chinese medicine practitioners who have been trained will be able to offer this. There has been a number of studies in cancer pain, and acupuncture has been shown in these studies to decrease pain. They even use what they call sham acupuncture. So they have a way of, instead of injecting the needle, they make it seem like you've had the needle put in, and then they can actually say, well, was it the placebo or was it the needle itself that was working? We generally say that it can reduce pain anywhere from 2 to 3 points on a 11-point scale, 0 to 10. So it can be very helpful there. And it also can be used in conjunction with other medications. So let's say that you're on some opioids, you're doing well, except for one general area. We can't really get on top of that. That's where acupuncture can make a big difference.
Yeah. So the research around acupuncture is fairly solid, it sounds like, because I know that in some cancer centers, they actually have acupuncture available in some of their integrated health centers there.
Right. And you bring up a really good point about this integration. Integration is a process of including some of the well-tested complementary areas that can make a difference for patients. So mindfulness would be a good example of that, a psychosocial intervention where you would be spending some time learning how to practice mindfulness, and you can actually work to help out with your pain. You may combine that with the acupuncture that we're talking about. Maybe you're taking a pill for a specific reason, like a pain medication, or you might be looking at some exercise, specific exercises that are going to be able to help it. And yeah, that whole integration of these complementary areas, you're using all of your benefits, all of the available benefits for you. And often we find that patients do much better. They're able to function a bit better. It also gives them more control, which I think is really important. We don't talk about this very much, mainly because of us doctors are very controlling. But patients come into the system, they lose that ability to guide a lot of their treatment because suddenly they're in a high-tech world. We're talking about chemotherapy where they don't know very much, or high-tech surgeries, things like that. These sort of treatments as integrative, they often are involving the patients right in it. Like mindfulness is a great example. You have to learn how to do it and you have to practice it. And once you practiced it, then you get some benefit out of it. It's different than just taking a pill.
Yeah. Can we talk just, I want to come back to mindfulness so that you can talk a little bit more about how that is helpful. Just going back to needling again,
Oh
this
yeah,
idea of
yeah.
these big needles. What exactly is being done there?
Now, again, this isn't an area that I have a lot of experience in, but my understanding is by using a dry needle injected in specific areas, we can help to break up some of the fibrosis or some of the issues that are causing pain. Excuse me. If there's some inflammation, sometimes these needles can allow the anti-inflammatory agents in our own body to get in there and to make the sort of difference. These practitioners, and again, a lot of them are rehab practitioners like Dr. Woodrow. They may focus in on an area and put the needle in several times, not like this, but rather, slowly and purposely, because they're trying to get the body to respond. They're looking at getting that inflammation or getting the body to the immune system to get moving on that. Some people have used this needling in conjunction with electricity. So you may have needles that are connected to a very small voltage of electricity, and you get that sort of transcutaneous stimulation. And that sometimes can help out with things, with the pain. There's also a really fascinating area called scrambler therapy that is being practiced in a few select areas around the world. It's mostly in the US, a couple in the UK that I'm aware of, where they're essentially using electricity to retrain the brain and the nerves in terms of their carrying of these messages. And they found some nice success with patients who have had peripheral neuropathy, especially from cancer. Unfortunately, it's not widely available in Canada yet. I believe that there's a center in Toronto that's supposed to open up. And it hasn't, it's still really thought to be experimental in the US. So it's been rather interesting to watch what's going on, and hopefully we'll see that come to Canada fairly soon.
Yeah, with the mindfulness, that's another area that's been researched a little bit more in terms of the complementary therapies that are out there, and that there is good evidence, not just anecdotal evidence, that people are finding it helpful. Can you tell us a little bit about how that works, how the practice of meditation can be helpful in terms of coping with pain?
I'll be honest, I'm not an expert in that area, but from what I understand, two things come out of it. One, you're trying to examine, you're spending time thinking very deeply, feeling what are the issues that are making this pain, where can we focus some of the energy, for this. Meditation allows you to clear the brain, allow you to focus in on those sort of areas. And often, if I understand this correctly, you often are given some term or something to focus on. And in doing that, you can help to remove or reduce the stress, the pain, the issues that you're focusing on. Many people practice meditation on a daily basis. They find that their bodies are, function better. They find that they have less pain. When you're talking about some of this, there are other types of meditation or psychosocial techniques, cognitive behavioral therapy, where you're using your brain to change your behavior. You're trying to make things better by really looking at what is it that you're doing. Are you doing things that may worsen the pain, unconsciously so? Can you make those differences? And it's always best to go to the experts on that. And again, our psychosocial colleagues, there's at least 1 or 2 experts there, and that's why they've been able to hold these sort of classes for patients and families.
Right, great. Let's talk a bit about medical cannabis. We have a couple questions about that already. So the research that's there, your work, in researching the use of medical cannabis with cancer patients.
Yeah, so cannabis this is one of those other things that have been around for millennia, have been used in a complementary fashion for a variety of reasons. Pain is one of the things that we know that people have been using cannabis for. There's some evidence, possible evidence that Queen Victoria used cannabis when she had menstrual cramps or during childbirth. It was very popular then as it was coming from India. But now Canada has legalized cannabis, both as a recreational product and then as a medical drug that we can use. And we've been able to use this for patients really in 2 ways. One, to treat conditions, so treat the pain, help out with the nausea. Does it make sleep easier? Yes, it does. But it also can be used as, how would I say it? It can relax people. It can make things feel a little bit better. They feel that they can handle the stress a bit better. So I think that that's another useful part of this. And also, again, people now can take a little bit of control in this whole situation. Is my taking a medical cannabis going to help me along the way? Will it make things a little bit better? It's a complementary thing because it can reduce the amount of other drugs or reduce the dose of the medication that you're using. We've done some research in our own clinic. We found that the introduction of medical cannabis for some patients reduced their need for some of the painkillers. We saw that they were functioning a little bit better. Definitely, we saw that there was an increase in their quality of life with the addition of that cannabis product.
Yeah. One of our audience members asked, can it be helpful for someone with metastasized brain tumor?
Yeah, and that's probably, we hear that often. Brain tumors are the one area where we have human studies of the use of medical cannabis. There's been 2 studies that have been published. Both of them showed that there was some benefit to patients, real humans, and I'll say why I say that in a moment. Real humans getting benefit from the medical cannabis. There may have been a shrinkage in the tumor, or people have lived longer while they're using chemotherapies. They get better results using medical cannabis. A lot of other studies have been done with cannabis, but it's usually using animal studies or animal models, cell culture, and those haven't necessarily translated to humans. We don't necessarily have a lot of what we call randomized controls or even clinical trials that can really confirm what we see in the test tube.
But with brain cancer, why did they select brain cancer patients for those studies?
It's because when you looked at the test tube and looked at the animal models, you had clear evidence of benefit there. There's several labs around the world that do this work, but some of the best are coming out of Spain. And they actually looked at human gliomas, human sort of cancers that they were able to grow in the lab. And they were able to identify a lot of benefits that come from the use of cannabis in this. The clinical trial that was just published at the end of last year showed that patients lived longer, as long as 50% longer, when they're using cannabis in conjunction with their chemotherapy, their temozolomide. So
Wow.
quite a significant, very small study, only 21 patients, but we're hopeful that we're going to see some bigger things come along.
Yeah. Are there other interventions that are being studied that that people are looking at in terms of complementary therapies to treat pain?
There's let me think about this for a little bit. Some of it, I mean, we touched on a little bit of it, things like physiotherapy. People can do some visualization that kind of is in the same vein as meditation. We know that although it's not as complementary, but we know that surgical interventions sometimes can help out with pain. You know, something simple like you stood up and you suddenly cracked a bone, you have to get that bone fixed. Sometimes it's a matter of, you know, can we make a change in the condition? Can we reduce the size of the tumor? Can we take the tumor off of the nerve, and in doing that make a benefit for the patient? So, you know, number of years ago, we would say, oh no, you can't do that because it's cancer. And yet we have a good cadre of physicians now who are saying, hey, you know, if we do this, we can actually make things better. We can palliate. We won't be able to cure, but the benefit is very real. And, you know, their quality of life goes up, patients' quality of life.
Let's launch that last poll and just check in with our audience what they've already tried themselves. So let me just launch that one. So this is our last poll, just to check in, what other strategies have you tried to manage pain? So we can check in there. Just while we're waiting for those results, a question from one of our audience members: what is your opinion on, and I probably won't say this right, lenalidomide?
Lenalidomide?
I guess that's how it is.
Okay.
Yeah.
Or thalidomide? Do they mean thalidomide or
I think it's
lenalidomide?
lenalidomide.
Okay, so they're talking about a drug that we use for myeloma. It's been an accepted drug. It's pretty standard practice now to use lenalidomide to help reduce the burden of myeloma. So it works as an anti-cancer drug. It is derived, though, from thalidomide. Thalidomide is the drug that was used as an anti-nauseant for mothers in the 1950s, resulted in some problems for babies that were born, you know, small arms, no hands, that sort of thing. But yet thalidomide does have some real impact, some real benefits to patients. You have to be very careful not to give it to someone who's in the fertile period, so you wouldn't be giving it to women who, you know, possibly could get pregnant. But it was one of the things that we started to use both as an anti-nauseant and found that there was some benefit in myeloma, and that's why we developed drugs like lenalidomide, and there's a few others that end in amide that have been used in that type of cancer.
Okay, I'm going to share the results with you for this last poll. So there's the feedback from our group. Any comments on that, Dr. Danick?
Well, the exercise, I mean, that's a great thing that people are using it. We know through, again, trials with cancer patients that more exercise kind of primes the immune system. It kind of gets kind of revs up, and in doing that, it can help to reduce things like nausea or fatigue. It can allow the immune system to work more effectively against the cancers. And we know that it can be beneficial for a number of different types of pain. And even just, you know, getting those muscles moving again. Many times when we're dealing with cancer, we're pretty, how would I say it? You know, we're not doing very much. We're sitting around, we're spending more time on the couch than we are on our bikes and things, just because of fatigue, just because of tiredness, or the fact that you're spending so much time at the cancer center. So I think that that's a really good thing. And I certainly recommend exercise to almost all of my patients, those who can do it. I like the fact that they have both mindfulness and massage. You know, a good 40% use both of those. Really excellent choices.
Great, yeah. And other therapeutic touch, that could be things maybe like Reiki or, you know,
yeah, absolutely,
like
absolutely. Yeah. Reiki is something that is practiced by a number of different people. And I know that some of the integrative centers across the country have incorporated Reiki. I don't fully understand it. I do understand that there are some people who get really great benefit out of it. The scientific mind of me would like to know a little bit more about it. So we're just waiting for some of those studies to come to pass.
Yeah. Somebody has a question about, is cannabis oil or I can never say that. Cannabinoid or something. Or is that oil?
Cannabinoids.
Yeah. Is that better than cannabis?
So cannabis in Canada now, with the medical programs, it's available in a number of different formats. You can get the dried cannabis and make a cannabis cigarette, or you can inhale it through a pipe or a number of like a vaporizer, or they've now developed what we call cannabis infused oils. There are capsules, there are gel caps, there are edibles. Some of these edibles contain a certain amount of THC or CBD. Those are the active ingredients for medical cannabis. So in some ways, it becomes easier for us to prescribe, if you will. I want you to have so many milligrams of THC, so many milligrams of CBD, and we can do that with two different oils, let's say a pure CBD or a pure THC oil. Or some people like the combination of THC, CBD, or just CBD alone. And we hear about people who are afraid of the euphoria or afraid of some of the potential side effects from the THC. So they're just starting out with CBD cannabidiol as a single agent.
Mm-hmm. And are people able to just buy this without a prescription? They can just go buy it on their own. Is that something you would recommend, or would you recommend they get a prescription?
I would recommend they get a prescription, partly because the physician or the nurse practitioner can help determine what you want to buy. You don't want to go to one of the recreational stores and they sell you $100 bottle of something and it doesn't work very well, or it just makes you high. And, that's what recreational stores are for. They want to be able to give you a safe, pleasurable benefit sort of thing. And it's usually a 19 or 20-year-old kid who's there who says, well, I've used Blueberry and I use AK-47, and this is the benefit I get. You come to see the doctors, we talk about levels, milligrams of THC, milligrams of CBD, timing of it, and for what benefit. CBD can be really good for things like anxiety, can be good for nausea. THC can be great for sleep, but you also don't want to start too high. You want to start kind of low, get the benefit without having the hallucinations or the paranoia.
Yeah. A question also for you about hypnosis or reflexology. Is that anything you're familiar with?
The hypnosis, yes, and hypnosis has been used in pain, both in chronic pain as well as cancer pain. And this isn't like the, you go to the arena or the concert hall and you see a hypnotist. These are people who really are working hard to reduce the impact of the pain upon your body. And most of those are people who, again, come from the psychosocial area. They've had training with that. One of the former psychosocial people that I knew was fully trained in hypnosis, and she was able to do that with some of her patients. Now, I honestly know that some psychologists are trained in hypnotism, but I don't know who that is. And I'm trying to find that out from a couple of contacts that I have with the Psychological Association.
That's cool. We have time probably just for a couple more questions. This is a question that's related more to the first part of our discussion, but somebody's asking what pain remedies work for chronic BMT graft versus host disease, such as joint pain or osteoarthritis.
And, that's some of our most challenging bits of pain that we have. The graft versus host, the changes that occur after you've had a bone marrow transplant and you've developed this, these are often chronic inflammatory conditions. So you're looking at either an anti-inflammatory, or now we're starting to look at certain types of monoclonal antibodies that can help to reduce the inflammation. There's a drug called ruxolitinib that has come on the market in the last couple of years that many patients with graft versus host disease are starting on, and they're seeing some benefit over time. Those are also patients that we've seen some benefit with the use of cannabis. I've had a few patients where they either have, muscle fibrosis, muscle spasms, trying to find or finding the right dose of cannabis product, suddenly they can really thrive.
I'm interested about what is gabapentin and how does that work? Because I hear it being prescribed for all sorts of things.
Yeah, gabapentin was originally designed as an anti-seizure medication. It was an anti-epileptic. Didn't do so good at that, but some people found that it helped out with their pain. The challenge with gabapentin, although it's cheap and it doesn't have a whole lot of side effects, only some of us contain a cofactor that allows it to be absorbed and for you to get full benefit out of it. So patients who get benefit out of a small dose often will get benefit out of a higher dose, and those are the ones that you want to continue with gabapentin. Many people, though, don't contain that cofactor. Their bodies don't produce it. So they're on huge doses of gabapentin, and all they're getting are the side effects like the dizziness, the ataxia, the dry mouth. There's a few people who have, their appetites get driven by this. They may feel sleepy all the time. So, in that case, the gabapentin is not a useful drug. It's just contributing to the problems. There's a related medication, something called pregabalin, that we've used. It's a better drug. You don't need the cofactor. You only need to take it twice a day. And it seems to be well tolerated for some of those patients who have these sort of nerve pains. It previously was not covered by pharmacare, but it now is covered. And because of that, I'm seeing more patients on it with better effect.
Okay, good. Another question, is there a benefit to bioidentical hormone replacement?
That's an area that's honestly outside of my practice. I do understand the replacement of hormones can be very important, and bioidentical means that you're working to find a way to take them. You might now be taking them orally, you might be using it topically or some other way. And I don't know enough about it to really comment. I think it would be best to bring that to the attention of either a endocrinologist whose practice is totally hormones. There are a couple of pharmacies within the city, though, that have some specialists there that might be able to get you a little bit more information. The Sinden Pharmacy, there's about 2 or 3 locations in the city, Sinden, C-I-N-D-E-N, and then Taché Pharmacy have some specialists in hormone replacement. So, they would be able to give you much better information than I could say.
Dr. Dinnick, is there a long wait list to get in to see a pain specialist?
For our pain and symptom clinics, we've adjusted them. And now, it's usually within 2 weeks, you'll see one of us. Oh, yeah, I see Ali's putting that on the chat. Okay. Yeah, right now it's 2 weeks or less. If it's a really urgent issue and the physician says, I need you to see this person as soon as you can, we can open up a spot, usually within about a week to 10 days.
Oh, that's great. Yeah, that's really good. Yeah, super. Lots of great questions from our audience today. Yeah, really, thank you so much, everybody, for all your really good questions. And I think we could continue to go on and on. There seems like there's just one of you doing this work. I mean, what would you like to see happen like down the road in terms of pain treatment? Do you have a vision for how things could be managed differently?
Certainly within cancer care, I think things have improved, and I see that there will be some improvement as well. As I said, we have this, Tamara is fairly new to us, and she's opened up a full practice or a full clinic of pain and symptom. She's wonderful to work with, very friendly too. We've just brought in a specialist CNS, a clinical nurse specialist or an advanced practice nurse, whose focus is going to be on patients with advanced cancers. And with that, there's going to be some help with pain and symptom. We also know that there was a recent graduate from Cancer Care Manitoba, from the training programs here, who will be relocating to Brandon and will be doing a pain and symptom clinic out in Brandon area. So, you know, there'll be a real specialist in the Prairie Mountain region. So we hope to see some of our work be diverted that way, because Dr. Anderson, I really like working with him. He's a good guy.
Awesome. Well, thank you so much. And thank you to all our audience participants for joining us and for all the great questions. And Dr. Danek, thank you so much for sharing with us today your expertise and such a great discussion. I really appreciate it.
You're welcome. You're welcome.
Take care, everyone. Thank you. And it would just a note, if you can complete our survey, we would really appreciate your feedback. So there'll be a link to that at the end of the webinar today. Thank you again.